Common musculoskeletal disorders. In this presentation, we will be discussing some common musculoskeletal disorders that you will see in primary care, including joint pain, osteoarthritis, plantar fasciitis, and Carpal Tunnel Syndrome. My name is Dr. Ajay. I am a board-certified FNP, and I currently practice at the Mayo Clinic Occupational Medicine Department. I also teach as a visiting professor with Chamberlain University. The purpose of this lecture is to enhance your knowledge of diagnostic reasoning and develop your skills in diagnosis and treatment of common primary care musculoskeletal disorder. The most common musculoskeletal disorder that will be covered are the following: shoulder pain, elbow pain, and wrist pain, knee pain, foot and ankle pain. Musculoskeletal complaints. Musculoskeletal disorders can be a diagnostic challenge for the primary care provider. Much of the diagnosis is dependent upon the patient's history combined with a good physical exam and understanding of the underlying anatomy and physiology. A useful approach to the initial patient encounter for any musculoskeletal complaint is to determine if the complaint is acute or chronic, articular or non-articular, inflammatory or non-inflammatory, localized or systemic in distribution. Here are some tips to guide this classification. Acute or chronic. Acute pain is a direct response to incoming external internal stimuli that is voraciously processed by the nervous system as a protective mechanism against further damage to the body. On the other hand, defining when pain symptoms become chronic can be very difficult. Generally, pain is considered chronic when symptoms extend beyond the expected period of healing. So acute pain, less than 3 months in duration. It's sharp, throbbing, pulsing, electric, burning in quality, moderate to severe intensity at first and decreases predictably over time, based on type of tissue injury. Edema is common and decreases predictably over time. Pain disappears once healing is complete. Mood tends to not change the patient's complaint. Pain provocation tests produce the patient's initial complaint. Pain is localized to the site of injury or can present in standard referral patterns. Result from something specific such as an injury or inflammation, while on the other hand, chronic is greater than 3 months in duration. Pain symptoms become more generalized, topographically and less localized to the site of injury or initial complaint. Pain referral patterns that shift in location as well as intensity, frequency, and quality. Pain that does not change with movement, rest, or over time. Patients usually report pain as a constant or continuous. It is less likely to be intermittent. Mood or current psychological status tend to affect or worsen the pain complaints. Articular disorders. Articular structures include the following: synovium, synovial fluid, articular cartilage, intra-articular ligament, joint capsule, and juxta-articular bone. Disorders of these structures are typically characterized by the following: deep or diffuse pain, limited active range of motion or passive range of motion or movement, swelling, crepitation, instability, locking, and deformity. Articular disorders are classified based on the number of joints involved. Monoarticular is 1 joint, periarticular is 2 to 4 joints, while polyarticular is 4 or more joints. Non-articular disorders structures include the following: ligament, tendon, bursa, muscle, fascia, bone, nerve, and overlying skin. Disorders of these structures are typically characterized by the following: painful active range of motion but not passive range of motion, demonstrated point or focal tenderness, physical findings far from the joint capsule, unlikely to see crepitus, instability, or deformity. Non-articular disorders are described as either focal or widespread. Inflammatory disorders. This can be idiopathic or infectious and usually present with all or some of the 4 cardinal signs of inflammation, such as erythema, warmth, pain, swelling, while on the other hand, systemic signs of inflammation may present, including the following: fatigue, weight loss, morning stiffness, fever, elevated ESR, elevated C-reactive protein, anemia of chronic disease, hypoalbuminemia, and thrombocytosis. Non-inflammatory disorders tend to be related to trauma, such as meniscus tear or meniscal tear, ineffective repair, neoplasm, pain amplification, such as in fibromyalgia. There may be pain without swelling or warmth, absence of inflammatory or systemic fixtures, minimal or absent morning stiffness, and normal for age laboratory testing. So, clinical history. When evaluating musculoskeletal complaints, a thorough patient history is essential and should include the following: age, occupational history, medication, leisure activities or hobbies, family history, onset with precipitating events, location, duration, characteristics, alleviating factors, relieving factors, and severity or limitation of activities of daily living. Finally, a thorough review of systems should include other organs or systems that may be associated with musculoskeletal complaints, such as skin in the case of psoriasis, GI tract, inflammatory bowel disease, scleroderma, eye, sarcoidosis, and nervous system, such as Lyme's disease, vasculitis, multiple sclerosis, just to name a few. Moving on to shoulder examination. Now let's start with a discussion on shoulder pain. Here is an image depicting the anatomy of the shoulder. Do take note of the acromioclavicular area, which is right here, rotator cuff, and the muscles and tendons, because most injuries occur within this space. The shoulder should be inspected for the following: deformity of the acromioclavicular joint, deformity of the glenohumeral joint, swelling, bruising, scars, and asymmetry. Palpation should begin with the sternoclavicular joint and proceed laterally along the clavicle to the AC joint. Scapular spine, feeling through the superior and inferior angles. Cervical and thoracic spinous and subacromial, bursa, and tendons. Shoulder range of motion. When testing range of motion of the shoulder, keep in mind the following: the forward flexion, normal, is 180 degrees. Extension, normal is to 40 degrees. Abduction, normal is to 120 degrees with the palm down, 180 degrees with the palm up. Internal rotation, ask the patient to rotate his arm across his back and walk the fingers up the back as high as possible. Recording this by vertebral levels as a guide, the inferior border of the scapula is located at about T7 or 60 to 90 degrees. External rotation, normal is to 90 degrees. Shoulder examination. Shoulder impingement syndrome test. For this test, the provider examines the range of motion at the shoulder. Both actively, the patient moves themselves, and passively, the provider moves the arm and the patient relaxes. This should always be compared to the uninjured side. For what is normal for every patient, but also compared to normal guidelines. Speeds test. Speeds test is an evaluation for bicep tendinopathy. This test is best performed when the patient is relaxed sitting position. The arm to be tested should be in a 60 degree of front flexion, with the forearm supinated and the elbow fully extended. To perform this test, the examiner forcefully presses down on the patient's arm at the forearm while the patient attempts to resist the pressure of the examiner. Alternatively, the patient attempts to forward flex the shoulder while the examiner resists. A test is considered positive if pain is reported in the bicipital groove. Weakness in maintaining the forward flexion position will also likely be noted. A positive test is indicative of biceps tendon instability or tendinitis. Tenderness on palpation of the bicipital groove also indicates bicipital tendinitis. When the provider stops pushing down on the arm, a sudden jerking motion may result. Pain at this point may indicate a positive test for subacromial bursitis. Shoulder examination includes, the other ones include Neer's test or Neer's impingement test, Hawkins test, drop arm test, belly press test, lift off test, adduction external rotation test, and Job's test. For detailed video impressions of all these tests mentioned above, please click on this link for in-depth details. So moving on to shoulder disorders, impingement syndrome. This is typically when there is pain on the anterolateral aspect of the shoulder. It feels like a catching sensation. So imaging, ultrasound or MRI is not necessarily helpful unless pathology is suspected. X-ray is suggested if there is a suspicion of fracture or dislocation. Treatment, conservative with relative rest, analgesics, PT, ultrasound-guided pretendinous steroid injection may be more effective than placebo injection for up to 12 weeks, but appears no more effective than NSAID or physical therapy. This is impingement syndrome, normal shoulder. Another shoulder disorder is adhesive capsulitis. It's also known as frozen shoulder. There are 4 stages of recuperation, which ranges from 1 month to 24 months. By the time it is at stage 4, it is almost resolved. Initially, it is a gradual onset of diffusely painful shoulder, which can be significantly restricted, then transition to passive and active motions in all planes. Imaging. This is not routinely indicated. MRI is not recommended in reoperative assessment for proper prognosis. Treatment. The patient should treat pain with NSAID and progressive range of motion exercises. Intra-articular steroid injections may be helpful during painful freezing phases. Prolonged immobilization should be avoided. And here's normal and what frozen shoulder looks like. Another shoulder disorder is rotator cuff tear. This is a weakness or decreased ability to move a joint, e.g. difficulty or loss of ability to abduct glenohumeral joint. The provider should suspect diagnosis in patient greater than 60 years of age or in younger patient with history of traumatic shoulder injury who have shoulder pain, limited range of motion of shoulder, and positive signs on exams of weakness or pain in the external rotation. Imaging. MRI, ultrasound, and MRI arthrography each appears to have high sensitivity and specificity for detecting full-thickness rotator cuff tear in patients with shoulder pain. Treatment. Conservative treatment is an option for small symptomatic tears. Consider surgical repair for patients with chronic, symptomatic, or full-thickness tears. Here's full thickness and partial. Shoulder disorders. Acromioclavicular sprain. AC sprain results in pain in the clavicular area after direct trauma. Imaging. X-rays normal acromioclavicular distance 1 to 3 millimeters, but distance shrinks with age. Compare X-ray with uninjured side. Treatment. Type 1 and 2 injuries should be treated with non-operative measures. Type 3 injuries controversially trend towards non-operative management, while type 4, 5, and 6 injuries typically are treated surgically. Conservative management include sling for 1 to 3 weeks and analgesics. This is normal, type 1, type 2, 3, 4, 5, and 6, which is the worst. Elbow disorders. Okay, let's now move on to the elbow and commonly seen disorders, which include elbow pain, epicondylitis, and Olecranon process. When evaluating the elbow, the provider should inspect for the following: 1. Erythema, 2. Scars, 3. Swelling, 4. Atrophy, and 5. Alignment, which is the carrying angle. Elbow range of motion. When it comes to elbow range of motion, the angles are crucial. The flexion should be between 140 to 150 degrees. Extension should be 0 to 5 degrees. Pronation, 90 degrees. Supination, 90 degrees. Elbow palpation. Regarding assessment and elbow palpation, the landmark to look for should include medial lateral epicondyle, Olecranon process, radial head, and the ulnar radial nerve. The common tests for the elbow include valgus stress test and varus stress test. Valgus, varus. Elbow disorders. Medial and lateral epicondylitis. Medial epicondylitis, popularly known as the golfer's elbow, Pain is often sharp in the medial epicondyle and radiates down the arm from the inside of the elbow. Pain occurs upon extension of the wrist or supination of the forearm, such as when gripping, twisting, or flexing at the wrist. There may be weakness in the hand or wrist as well, or numbness and tingling in the ring and little fingers. The difference between the two is based on location of the pain. Lateral epicondylitis, popularly known as tennis elbow. Pain is often sharp in the lateral epicondyle and radiates from the outside of the elbow and down the forearm. Pain occurs upon extension of the wrist or supination of the forearm, such as when gripping and twisting. There may be weakness in the forearm or a weak grip. Imaging, usually unnecessary, but it may be useful if needed to rule out alternative diagnosis. Treatment. The patient should be educated to avoid or alter activities responsible for symptoms. Physical therapy may be used to speed improvement or recovery, and braces may reduce pain and improve function. Treat with topical NSAIDs. Steroid injection for lateral epicondylitis may provide short-term pain relief up to 12 weeks, but result in increased pain and recurrence at 1 year. Thus, work-home restriction is key to improvement and recovery. Olecranon bursitis. The most common symptoms of elbow bursitis is swelling at the back of the elbow. The swelling occurs over the proximal olecranon with tenderness reported in 20 to 45% of cases. A septic bursitis is more likely than septic bursitis. If septic bursitis is suspected, aspiration and analysis of the bursal fluid is necessary, as treatment with antibiotics may be necessary. Imaging, not typically indicated. Ultrasonography of elbow for olecranon bursitis may show bursal wall distension for more effective aspiration. Treatment. Aseptic. Most can be treated conservatively with padding on elbow and modification of activities. In most cases, it resolves on its own. In some cases, a steroid injection may be considered if bursitis interferes with movement. For septic bursitis, aspiration with GS and culture to guide the antibiotic therapy is needed. But the provider should start empiric treatment or therapy with a broad-spectrum antibiotic in the meantime. Arm, hand, and wrist disorders. The most common possible arm and wrist injuries include metacarpal fracture, distal radius fracture, Carpal Tunnel Syndrome, DeQuervain Tenosynovitis, trigger finger, ganglion cyst, phalanx fracture, scaphoid fracture, scapholunate dissociation, Jersy finger, flexor tendon disruption, and jammed fingers. Metacarpal fracture. The fourth and fifth metacarpals are the most commonly injured and are known as the boxer's fracture. These can result from a fall, crushing injury, or direct contact spot. Symptoms of a broken metacarpal fracture include swelling, tenderness, deformity, inability to move the finger crosses over its neighbors when making a partial fist, and or depressed knuckle. The provider should always assess for angulation, digital rotation. After the alignment of the metacarpals arrangement, pattern must look and feel stable. If comfortable with casting and splinting, the wrist can be splinted at 30 degrees of extension for 5 to 7 days. Then short arm cast application for 4 to 6 weeks. However, referral to orthopedics is appropriate, especially if there is angular rotational deformity or when the base of the fifth metacarpal is displaced or comminuted. Distal radial fracture. A distal radial fracture usually results from a FOOSH injury. FOOSH is an acronym for fall on an outstretched end. This really describes the mechanism of injury very well. Symptoms of a distal radius fracture include immediate pain with tenderness when touched, bruising and swelling around the wrist, and possibly a deformity such as the wrist being in an old or odd location. Imaging, take AP lateral x-rays to confirm fracture, while treatment, removable wrist splints for 4 to 6 weeks, which are preferably in minimal displaced fractures. A referral is appropriate upon confirmation of fracture but can be managed in primary care if the provider is comfortable with casting and splinting. Referral is needed when the fracture is displaced, open, intra-articular, or involving epiphyseal plates. Carpal Tunnel Syndrome. Carpal Tunnel Syndrome occurs when the median nerve, which runs from the forearm into the palm of the hand, becomes constricted. The carpal tunnel is a narrow passageway of the ligament and bones at the base of the hand that houses the median nerves and the tendons that bends the finger. The median nerves provides feeling of the palm side of the thumb and to the index, middle, and ring finger, but not to the little finger. A common cause of carpal tunnel syndrome is repetitive activity with the hand that cause irritated tendons, causing compression of the median nerve. Symptoms may include burning, tingling, or itching, numbness of the hand and fingers, especially the thumb, middle, and index finger. Symptoms usually start gradually, and the classic presentation is the patient will complain of waking up feeling the need to shake out the hand or the wrist because of numbness. This is because most of us sleep with our wrists flexed. As the condition progresses, symptoms may occur during the day and weakness ensues, making it difficult to grasp small objects or perform manual tasks. In untreated cases, the muscle of the base of the thumb loses innervation and atrophies. Right here, the base. Carpal tunnel syndrome diagnosis. Carpal tunnel syndrome is made primarily as a clinical diagnosis with attention to occupational and leisure activities. Physical exams should include testing of upper extremity, strength, and sensation, as well as reflexes. A phalanx and Tenosynovitis test should also be performed. In the Tenosynovitis test, the provider taps over the median nerve of the affected wrist. The test is positive if tingling occurs in the affected fingers. Phalanx maneuver or wrist flexion test involves having the patient pressing the back of their hands and fingers together with their wrist flexed as far as possible, ideally 90 degrees. The test is positive if tingling or numbness occurs in the affected fingers within 2 to 3 minutes. It may not happen immediately. Confirmatory testing can be done with an EMG or nerve conduction test, which can evaluate the severity of the neuropathy. But it is important to know that the symptom must be present for at least 3 months before an abnormality will be detected on EMG test. Treatment: start conservatively with nocturnal wrist splints that extend the wrist upwards, taking pressure off the tunnel. Surgery is reasonable to offer after failure of conservative therapy for 3 months, because delayed surgery appears as effective as immediate surgery with 94 versus 92% success rate. It is important to know that NSAIDs, vitamin B6, and diuretics are not effective. DeQuervain's Tenosynovitis is an inflammation of tendons on the side of the wrist at the base of the thumb. This tendon include the APL and EPB tendons. These tendons pass through a tunnel located on the thumb side of the wrist. Any swelling of the tendons results in increased friction and pain with certain wrist movements like Carpal Tunnel Syndrome. DeQuervain tendinosis may be caused by repetitive movement but is also associated with pregnancy and rheumatoid disease. It is most common in middle-aged women. The main symptom is pain. It's felt over the thumb side of the wrist that may travel up to the forearm. The pain is worse when forcefully grasping objects or twisting the wrist. A catching or snapping sensation may be felt when moving the thumb. DeQuervain syndrome is a clinical diagnosis based on history and physical. As with Carpal Tunnel syndrome, attention should be made to occupational and leisure activities. Physical exam should include testing of upper extremity strength and sensation as well as reflexes. And the confirmatory test is the Finkelstein test. The Finkelstein test is performed by having the patient place their thumb against their hand, making a fist with the finger close around the thumb. The patient then is asked to bend the wrist forward toward the little finger. The test is positive if pain is reproduced over the tendon on the thumb side of the wrist. Treatment includes splints to the rest of the wrist and thumb, insets, and avoiding aggravating activities. A corticosteroid injection in the tendon sheath is usually effective. Surgery will be recommended if symptoms are severe or do not improve. Time to recover when treating conservatively is 6 to 10 weeks for early cases and 3 to 6 months for chronic cases. Jersy or trigger finger. Jersey finger, also known as trigger finger, is a condition where the tendon in the finger or thumb are inflamed, making it difficult for the finger to slide through the tendon or tendon sheath. Trigger finger limits finger movement, and when the patient tries to straighten the digit, it will lock or catch before popping out straight. Trigger finger often involves a disruption of the FDP tendon near the DIP joint. Trigger finger is more common in women than men and occurs mostly in people between the age of 40 to 60. Trigger finger is also a clinical diagnosis, so a thorough history and physical exam of the upper extremity is important. The patient can demonstrate the deformity during examination. Testing is not needed, but in some cases, the provider may choose to perform AP lateral oblique X-ray to rule out other pathology. Treatment is conservative with rest and insets, and steroid injection may be helpful. Surgical correction is usually necessary to correct the problem and is reasonable to pursue for failure of conservative treatment. Let's move on to the most common knee conditions that you will see in primary care. These include patellofemoral syndrome, osteoarthritis, ligament sprain, meniscus tear, patellofemoral syndrome. It is a broad term used to describe pain in front of the knee and around the patella. It is sometimes referred to as runner's knee or jumper's knee because it's common in people who play sports. However, the condition can occur in non-athletes as well as regular people. The condition occurs when nerves sense pain in the soft tissue and bone around the patella. The soft tissue includes the tendon, the fat pad beneath the patella, and the synovial tissue that lines the knee joint. In many cases, patellofemoral syndrome is caused by vigorous physical activity or a sudden change in the activity or intensity of an activity. Pain is typically in the anterior aspect of the knee that occurs after a period of strenuous activity but is relieved with rest. Diagnosis is made by history and on physical. The pain can be reproduced when the patient asked to squat. X-ray may identify osteochondral arthritis, which has a similar presentation. Treatment is conservative and includes activity modification, muscle strengthening, and physical therapy. Another knee disorder is osteoarthritis of the knee. OA of the knee is a progressive disease of the joint that occurs when articular cartilage that covers the end of the bones gradually wears away. Where there was smooth articular cartilage that made the bones move smoothly, there is now a frayed and rough surface. Joint motion along this exposed surface is painful. OA can affect any joint in the body, and symptoms can range from mild to disabling. OA of the knee is the most common and is characterized by recurrent knee pain that worsens with activity. It may also be associated with crepitus and knee instability. Imaging. Plain radiography is considered the gold standard for morphologic assessment of knee osteoarthritis, while treatment acetaminophen is recommended as first-line therapy. Cortisone injections provide short-term benefits. Hyaluronic acid may be helpful, but the evidence is conflicted. Indications for total joint replacement include refractory pain and disability and radiographic evidence of knee osteoarthritis. And here you can see this arthritis is very evident, and this is the good part. Ligament sprain or tear. We will discuss the ligament sprain and tears of the knee briefly, as most of these end up being referred to orthopedics for treatment. However, it is important to understand the signs and symptoms of each condition as well as the maneuvers to test them. These maneuvers are demonstrated in your physical assessment textbook, so I will not go over them here. Ligament strains or tears occurs after some sort of injury. Symptoms include acute pain, swelling, and possible instability. Physical exam should include the valgus and varus test, which test the MCL and LCL respectively, and they're performed at 30 degrees and 0 degrees. The ACL and PCL are tested using the anterior drawer and posterior drawer test. Below are the links that will show you step-by-step impressions of how these tests are performed. Imaging should start with X-rays, and an MRI should be performed if there is a high index of suspicion for ligament tear. Treatment for partial tears include aspiration of blood, effusion, possible arthroscopy, immobilization, padded splints, knee immobilizer, and circular cast for 3 to 4 weeks. Then begin vigorous rehab of quadriceps and hamstrings. For a complete tear, surgical repair should be attempted as soon as possible, best done within 48 hours, although it is possible even 10 days post-injury. Meniscus tear. The symptoms typically exhibited by these patients include knee pain, swelling, knee locking, sensation of giving way, painful snapping or clicking. McMurray's test and the Apley's compression test are performed to evaluate the meniscus. Here you have McMurray's and the Apley's test. Imaging. MRI evidence of meniscal tear is very common in asymptomatic patients and patients with osteoarthritis. Treatment. Arthroscopic surgery for degenerative meniscal tear does not improve pain more than conservative treatment. In patients with mild or no concurrent osteoarthritis. Lastly, we will discuss common ankles and foot disorders that you will see in your practice. The most common injuries are ankle sprain, plantar fasciitis, Achilles rupture, bunion, and toe fracture. Ankle sprain. This occurs after some injury and is a tearing of the ligament of the ankle when the ligament is stretched beyond its limitation. The most common ankle sprain occurs on the outer lateral aspect of the ankle. Injuries where the ankle is rolled inward, inversion, will produce a lateral ankle injury, whereas outward or eversion injury produce medial ankle injuries. Ankle x-rays are only required if pain is in malleolar zone and any of the following: bone tenderness at posterior edge or tip of lateral malleolus, bone tenderness at posterior edge or tip of medial malleolus, inability to bear weight both immediately and in emergency department. The history and physical exam are key. Treatment involves FRICE, which is protection, rest, ice, compression, and elevation. Acetaminophen or NSAID may be used to reduce pain. Ankle and foot disorders. Plantar fasciitis. Plantar fasciitis is an overuse injury that affects the thick band of tissue, fascia, connecting your heel bone to the base of your toes. The condition typically starts gradually with mild pain at the heel that is often referred to as stone bruise and is more likely to be felt after exercise. Plantar fasciitis is a clinical diagnosis, and the hallmark symptom includes pain with the first morning step or after a period of sitting. Treatment includes stretching, shoe inserts, arch support, orthopedic shoes, night splints, insets, and possibly steroid injection. Achilles Tendon Rupture. It is a complete tear of the tendon and typically affects men over the age of 40 who are involved in recreational sports. Symptoms include a sudden sharp pain in the Achilles tendon. A loud snapping noise or bang may also be heard. A gap of 4 to 5 centimeters in the tendon can be felt immediately after the injury but may be less obvious later, as well as swelling increases. There is a considerable loss of function, and the patient usually needs to limp but may be capable of walking. This is also a clinical diagnosis. This is usually a clinical diagnosis that requires an MRI if uncertain. Should this type of injury present in the clinic, an immediate surgical consult is needed because the sooner that it takes place, the higher the chance of success. If the injury is greater than 2 days old, the chance of a successful outcome decreases. And here is the bad leg with the injury, and here is the ankle without the tendon rupture. Conclusion and pearls. Overall, keeping the plan of care simple and short is key to successful treatment of musculoskeletal disorders. Approximately 85% of musculoskeletal disorders can be resolved with exercise, stretching, physical activities, or physical therapy, over-the-counter medications such as NSAID, walk restrictions, and proper implementation of ergonomics. The goal is to improve the patient's physical function, increase comfort, decrease pain, teach cognitive behavioral therapy, and strengthen main muscle groups. The worst and most harmful treatment that can be provided to patient is bed rest, except in the case of fractures. Finally, primary care providers should know their scope of practice and refer in a timely manner for quick recovery.